Good afternoon, thanks very much for inviting me. My name is David, I'm the CIO at MFT. Obviously you're familiar with this campus here, but we've got 10 hospitals within the group, but also community services as well across Trafford and Manchester. So I wanted to sort of set the scene today around what we're doing with wearable technology, where we think this can go, what the opportunities are, and why Greater Manchester as a system is somewhere that's really leading on this, and we want to lead further. But like our first speaker, I am ridiculously optimistic. I am also a Tottenham fan. So there are two things that haven't gone together very well for the last 9 months, but hopefully this will frame it positively for everybody. So when we talk about the challenges, we touched on these, we've heard as well, but if you look at the Health Review 1984, it's got everything that's in the 10-year plan minus the analog to digital, and that's only because the digital didn't exist there. So a lot of the ambition isn't necessarily new, but if we look at what's driving this now and the opportunity that digital presents, digital in itself will not fix everything we need to fix to have an efficient healthcare service. But if we don't do the digital right, we have got a catch chance of fixing what we need to do for the NHS. We're making some very stark decisions over the next decade. I did see my phone flashed up that the Secretary of State has resigned while we're in the room, so but we would have to make some stark decisions in the next 10 years because fundamentally demand is going up, the age population is going up, inequalities in the country is going up. There's been historical underinvestment in lots of areas for lots of reasons. In an acute hospital background that I'm from, we do okay for funding mental health. I don't think we can say the same. Social care, I don't think necessarily we can say the same. So there's been some investment inequalities, and we've got a sort of ageing population and demand is going up, they're facts. So if we want to fund that, we've only got a few ways of doing it, and that's to probably triple level taxation, well that's a vote winner. Or we start rationing services, and that's a vote winner. And fundamentally we all believe, or I hope we all believe, I certainly believe, passionately in universal healthcare, free employment care, and what the NHS stands for, so therefore we have to embrace the change that we need to do. And I think probably is expected now. And apologies, for everyone that hears me speak, I'll say this line, it's like a stuck record, but it is my favourite quote that I think I invented, but it's also possible I stole it somewhere online. And that's that all technology that exists when you're born is normal. And all technology that's invented before you're 21 is a career opportunity. And if you follow it through to, my father used to say, any technology that's invented after you're 70 is evil, morally bankrupt, and needs to be turned off. So there's a range. But if we accept that all technology exists when you're born is normal, and if we accept that in effect the internet age, as we recognise it today, sort of 2000, 2001, 2002, really, where we've normalised it, that means that everybody who's now 25 years old, this is normal. That means all doctors coming out of training from university, this is normal. For all the kids going through school, this is normal. So the transition that we talk about is actually for those of us that it's not normal. And obviously that not normal gap gets smaller over time by definition, and we do have an obligation to make sure that we're not doing anything to widen those inequalities. My challenge though is I don't think the way that we currently provide care is equal. We're scheduling appointments for people at 9 o'clock in the morning when they've been on night shift, and then we wonder why they don't attend the appointment. So actually, we're not starting a vision of perfection, and I think we need to remember that, because sometimes that sort of delays the need to change. But if you take analog to digital, I was one of the authors of that section of the long-term plan. We were told by the Secretary of State at the beginning that we were to be as ambitious as we wanted to, because it was for the politicians to dial down the ambition. So we submitted about 8 chapters, and 6 got through. And some of them we've heard about today, single patient record, for example, NHS Online, the use of much greater use of AI. Some of that, though, will require legislation changes. Some of those are coming. With that comes some degree of complexity, and we probably need to change in the way that we regulate what we classify as a medical device, or at least some of the innovation with the MHRA. And Lawrence at the MHRA is quite a transformational sort of thought leader in this space, and I think we are shifting that down nationally, because if we don't, all health tech innovation is going to go to Europe or elsewhere in the world anyway, and then we get left behind as a population. So I think we're on the right track. Oh, animated slides. Right, so what we're going to touch on is what I think are the 3 truths we need to focus on when we're talking about this. One is pathways, the second one is the tech, and the and the governance around that tech. And the third one is data integration. We cannot, coming back to the point earlier, create another data silo with another data system with another number of steps for people to work on. We have for decades now been improving digital within health services globally, but specifically in the NHS. But what we've managed to do is to have a better scenario where we're not removing the steps that it's there to replace. We're getting much more digitised, but there's lots more steps. And there has to be a step back and reflection point on that. And I think that's now being driven. Coming back to, it's normal now for a lot of people, so actually people are expecting that to be different. The other thing is we have a planned, very rare planned, but occasionally we do the upgrade to our electronic patient record system. You should see the look of horror on a 26-year-old F1 straight in their first placement when we give them a pen. So, if we work with the truths, so I think the first truth we want to touch on is pathway redesign. Okay, so you've got to redesign the pathway and then decide the technology to put it in. We can't put technology in it because it looks nice and then redesign the pathway. That doesn't mean, however, that we need to spend the next 3 or 4 years determining what that looks like to be able to put that tech in, because there are use cases now. All this we've heard, and Karen, thank you for sharing your story. I'm a Crohn's patient. I've been a Crohn's patient for 20 years. I've been inactive for 14, 15 years. Inactive because I've got no testing. So it's quite hard to have Crohn's disease when there's none left. But I still have to go to the hospital appointment every year. I still have the car parking experience. And all he does is ask me how my mum is. She's used to be medical secretary, there's no drama. And the most embarrassing thing about it is, they weigh you every year as well. So I go there, and it's one of those sit-down scales, which I'm sure is materially out of the home one. And I think, actually, I'm a prime candidate for what we call PIFID, so patient-initiated follow-up, where actually I should initiate my appointment at a time that suits me, when I know that I've got some of my symptoms, because I know the symptoms days, weeks in advance. And we've got tools now, algorithms and AI that we're developing, and Henry's here, we've got some in diabetes at the moment, Henry, we've got some going into asthma. That could be looking at those patients that are on those lists that just don't actually work there, deteriorating, and that links through to the Greater Manchester Care Record that we touched on earlier. So that's really quite exciting. But we almost need to flip that to the next level, which is we need a better name, because I can't think of an acronym beyond DIFID at the moment, but we need a digitally initiated follow-up, which actually calls those patients into their appointment so that they don't feel as though they have to wait when those indicators look as though that's at that point. But to what we've heard, we can't have that into the admin burden, so clinicians and nurses and administration staff. That has to be part of the process. So we must redesign our pathways. And some of this you'll hear about, and you hear about it because it reaches the news for the controversial sides of these changes. But at the moment, you know, you may need a diagnostic test for your referral. And yet you have to go to Virgin's Hospital to have the appointment to get your car park appointment to go for that diagnostic test. So some of the ambitions is that the primary care, if it is primary care, should be able to refer you directly for that diagnostic. You know, those sort of things are what I mean when I'm talking about pathway changes. I think when we're talking about this tech, and I'll touch on what this means for Manchester in a moment, it starts with the virtual ward concept. The virtual ward concept was great because it was about early acute discharge from hospital ward. The economic model for it, I don't think ever really stacked up, simply by the scale, because you can't send it out to everybody. What I'm talking about today is health tech that prevents people from entering hospital in the first place. That's sort of ambition number 1. And mission 2 is tech that can help people inform the best pathway and treatment for them, based upon their biomarkers, rather than just the same approach each time, because not all size fits all, and everybody has sort of variable conditions for the ways that they manage their conditions. So I think that's where I want to see wearable tech coming through quite a lot more. You know, we touched on the governance. I think, as I said, the MHRA, those that don't fully understand what I mean, well, I'll have to for a coffee afterwards and I'll try and explain it. But in effect, we need a way of regulating what these devices are, but on the same token, we've got to get to a position where we can use. There's a difference between diagnosing and giving somebody a condition and tracking and monitoring the condition. Most people have got a smartwatch on, I guess, in the room. You know, to be able to use that smartwatch and consumer-based technology to take observational data, it's fine. What we need to make sure, though, is that there's been an order that's been in place, or something that tracks what we want to then collect back into the medical record, and what we've determined is normal and abnormal. And we need the patients, and this is why I'm quite passionate. In fact, one of my parts in the 10-year plan, I got a bit passionate, it made it into, well, half of it made it into the thing. We need to flip this much more into the patient needs to consent. consent question. To your point, not everybody wants to consent. So what we've done in Manchester, with the wearables, and Anthony and the team are outside, for those that haven't seen it, go and have a look, it's terrific. But in effect, you connect your device, or a device that we issue, one or the other, connect that to your smartphone. I'm an Apple person, so Android doesn't exist. You can do it on Google. You then connect that to your Apple Health then connects it into the Apple EHR. Again, so your audit's being in place and you'll be able to see outside that run in real time. Because once I've got it there, I can take it out and put it into our data research environment, which means then we can start looking at what impact has that had, and then that offers opportunities for researchers and real-world evidence. So, but we've got to keep patients at the centre of these conversations. I don't want a situation where everyone pitches at the MRI, and then I'm in Manchester, we're going to use that now because this digital person's giving us all a patch to go home with. And we also need to think about a sort of a sensible approach to this, and I jest, but we don't want a situation where we issue patients with multiple conditions, multiple devices, to do multiple monitoring. We need a way that we can aggregate that. And if you think about it across multiple care providers, how does that work when it might be, you could be a patient at MFT at the same time you're a patient at Christie, or at the same time you're a patient of community mental health services. If we all play this game, does that mean they've got 3 devices to aggregate, 3 sensors or watches? It's got to be one. So there's a bit to do there. This is moving through, is it? There we go. Okay, tap personal. And then we need to get data into the record, to record. It has to. Now, for MFT, we're fortunate because we can. That's not the same across the whole of Manchester, but the rest of Manchester's getting there. It's certainly not the same across the rest of the country, but that's why I think Manchester's uniquely positioned. We are in a much better position than anywhere else in this country to take record data, remote data, and put it real time into a patient record, and pretty real time into the research environment thereafter, based upon consent. Which I say is the basis of consent is to get consent. That's not just any more than that. And I think if we, in the scenarios we're given, I think if we clearly articulate to patients the benefits of it, I think most patients will take it. From our MyChart perspective, so MyChart's our patient portal app, slightly different to the NHS app, because MyChart's really a medical record in your pocket. Fully integrated with the NHS app, which is great to have one front door. But our MyChart app is used by 98%, 99% of all women on maternity pathways, and that's across all demographics. So the ability now to be able to take hypertension type monitoring, or diabetes monitoring of those women during pregnancy is terrific, because when we talk about pathway redesign, I don't think antenatal services have changed for about 30 years. As a man, I get sort of astonished at the quality of services that we offer women at times, and I won't get on that soapbox because I'm a white middle-aged man and it's not my position. But if you look at antenatal pathways, we're asking most women to come to hospitals 3-4 times from an antenatal pathway. They're professional working women who now have to take more than enough work to come in, or we send a community midwife out. And it's like a DHL parcel delivery service. Because you get a text message that they're going to be here between 9 and 12 on Thursday. So that's not now convenient around people's lives, and we need to be much more flexible, and I think that's when the remote monitoring, etc. comes in. So you've got to get into the patient record, which we can do in Manchester. We've got to research this to prove the utility, which I think we do very well here, and there's lots of tablets out, and Anthony and the team in the RNI team here, I see, and certainly Health Innovation Manchester too, can explain what we're doing here in Manchester on that sort of utility and research. We've got to prove that there's an output, that there's a benefit, of course. And we've got to prove that there is a value. I don't necessarily mean the pound value, right? I mean the patient experience value as much as anything else. But there's got to be a value, otherwise we just layer it in more steps. I think in Manchester we're in a position to scale us up. As I say, we've got 700, no, I just made that number up, right? 670,000, isn't it?
Almost 700,000.
700,000. So we've got 700,000 people using MyChart in Manchester at the moment. We're about to deploy into the community services, so I expect that to get to 1 million over the next few years. So you can see the power. We've got 700,000 today that we can potentially connect to with tech. I'm conscious I've got 2 minutes left, so I'll rattle through. But what we've already achieved in Manchester, so we've already done the clinical insights, we've already developed the evidence base, we've already got the relationships with industry. And we're already making the changes, as you've heard in the rheumatology example, in this direct patient care, but we want to go further, faster. And we give an opportunity here at scale, which I think is quite unique. Certainly MFT is the biggest trust in the country, but the Manchester population is also really diverse. And we have to remember, come back to the equality point, there are some ridiculously sad facts about inequality in Manchester. It's the amount of people who live on a disposable income of less than £10 a month is double-digit tens of thousands. 40% in Warren, 40-50% of children live in poverty in Manchester. And we've got a social responsibility for that, but from a health perspective, we need to make sure that we're not leveraging anything to make that worse. I won't go for the next steps because I think I've touched on those. And then from our ecosystem perspective, I'll just end on, we are leading those conversations with regulators with regards to what we can do around the destination of these devices. I think we're leading the country with regards to collecting data and putting it into a health record that we have empowered our patients to have full access to, probably based on the consent model. And there are some terrific research examples. We see with rheumatology, there's several cancer research studies out there. There's a few stands again that can touch on those. So we've got the research in the academic infrastructure. And I think we've got to drive in Manchester. Now this end, and again, apologies for those that heard it before, but Manchester was the birthplace of the NHS. It was also the birthplace of modern computing. And it was the birthplace, well not birthplace, but the starting place for women's equality. And I think wearables gives us an opportunity, actually, in the digital transformation to reinforce Manchester's position for the next 100 years in leading that for the saviour of the NHS.